Okay, I'd love to introduce our speaker, Lexie Wille. Lexie is a third-year counseling psychology PhD student who is interested in studying LGBTQ healthcare, health disparities, and health access. For this study, Lexie and Lexie's team conducted individual qualitative interviews with local medical students and residents to ask them about perceptions of their medical training in terms of LGBTQ-specific care. They also interviewed LGBTQ adults in the greater Austin area to hear about their positive and negative healthcare experiences, as well as what they think healthcare professionals know and don't know about how to care for them. Lexie will present themes that emerged from each group's interviews and future directions for creating more positive and affirming healthcare experiences for LGBTQ individuals in Austin and beyond. So with that, Lexie, I give you the floor and yep, okay.
Cool, thank you, Yona. Hey y'all. Yona did a great job introducing me, so I'm just gonna kind of get right into it. These are results from a qualitative analysis that we conducted this summer here in Austin, Texas. All of our interviews happened over Zoom, which was a happy accident of the COVID-19 pandemic. We were intending to do kind of in-person focus groups, and that's kind of what we ended up with. So I want to share kind of the perspectives that we were interested in hearing their experiences from. So medical students' perceptions of their training related to LGBTQ-specific care. And then simultaneously with that, LGBTQ adults and their perceptions of their past healthcare experiences, both positive and negative, and kind of how they think that those healthcare experiences could be improved. So I'm going to start with the medical trainees perspective and just talk a little bit about the sample that we spoke to. So it was kind of, it was made up of 50% Dell Medical students, and the other half were residents at Dell Medical School. So those residents received their medical training elsewhere, and then were residents at Dell currently. 100% of that population was cisgender. 66% were non-heterosexual, so any combination of queer, bisexual, etc. The average age of our sample was 28. And then 66% of that sample was white and 33% were Asian or Asian American. So obviously not a really diverse sample in terms of race. We distributed or advertised our study amongst all medical students through medical students that we were working with. And so we're thinking that this sample might be just kind of more representative of the demographics of medical students in general. So I want to highlight some themes that came out of speaking with the medical trainees. Oh, and before I get into this, I don't want to talk for just 40 minutes straight. So if y'all have a question, please stop me or put it in the chat, and I'm happy to answer that as we kind of go along. So don't be afraid to interrupt me. So I want to just highlight themes that kind of emerged from speaking with these medical students. And the primary one was related to teaching and training. And so most participants expressed some kind of desire for LGBTQ 101, kind of an introductory course on how to interact with LGBTQ patients, how to ask for and use pronouns appropriately, how to take a sexual history in an affirming way. Folks kind of reported that that's a little sporadic, and it's not really consistent throughout care, that it's kind of tossed in at the end of a particular system rather than receiving its own dedicated lecture or course. One thing that folks said was really consistently said that was the most impactful and important part of their training that they did experience was hearing from LGBTQ patients on a community panel. So a lot of folks have a transgender, gender diverse, and sexually diverse patients come in and talk about their experiences. And pretty much everyone said that they learn more from hearing about experiences than any other lecture or any other part of their education. The other was that a desire to work in LGBTQ clinics. So some participants were able to get rotations in the KIND clinic, which is an LGBTQ oriented sexual health clinic here in Austin, but identified in general that even with what sounded like the small amount that they learned in lecture, they were wishing that that would be supplemented with actually interacting with LGBTQ patients with identity related concerns, and that was not really available at this time, or they had to seek it out directly, that there's not really any longstanding relationships between the medical schools and LGBTQ community clinics, especially, or at least here in Austin. The other theme that emerged was that that students and trainees believed that in-depth training was necessary for particular specialties like primary care, internal medicine, endocrinology, and adolescent care. That those populations in general would be coming across LGBTQ patients and needed kind of above the LGBTQ 101 education level, that they were looking for more specific healthcare related training, like providing how to provide PrEP, how to provide gender affirming care in general. So I want to highlight a couple quotes throughout this presentation, as I think that kind of gives you the best idea of what patients were expressing. So one of the questions we asked was, what LGBTQ health topics need to be covered for all providers versus individuals? And then also, should this training be mandatory or elective? So this was a first year medical student who talked about a little bit about the education that they get in terms of talking about pronouns, the understanding of the continuum of gender and sexuality, but they don't talk about it as a class. They spoke about being rushed over and expecting students to do research themselves, and expressing a desire in learning about how to make a clinic more inviting for LGBTQ folks, making forms more inclusive, so administrative forms when patients are checking in, and understanding what language to use with patients. And then this was a second year medical student, and they spoke about that regardless of whatever topics are covered, that the biggest thing is that it's mandatory. So they spoke about doing an allyship training where 6 or 7 of the students went, and they were kind of talking amongst themselves that the people who were actually attending the training weren't really the people that needed allyship training, that it's sort of a self-selecting group that is seeking out additional training experiences, and that a big step forward would be making it mandatory for all students to have kind of a baseline understanding of LGBTQ population health concerns. So another theme I want to touch on is we asked participants about, once we kind of established that there was a desire for more training, what is the best way to do that? So a lot of people spoke about having in-person experiences and small group discussions, that it starts early in their education and it is a repeated exposure throughout their education. Folks also identified that online modules would not be effective. So that was kind of something we had tossed around, that maybe it would be helpful to create sort of an online module that people can watch, and then the curriculum doesn't have to adapt at all. There's nothing that needs to be cut out or adjusted. But folks consistently said that, there's a million online modules to watch, and it's something that folks just want to get through, and that it's not really an effective way to learn, that in-person dedicated lectures and then also clinic experiences were the ways that real learning would happen. We also asked folks about the benefits they believe would come from LGBTQ specific healthcare training. A lot of folks talked about more patient honesty and trust in their provider, which would lead to better care and outcomes, that it would build and develop empathy on the behalf of providers, that it's another group to kind of enter into with a sense of humility, to not make assumptions going into a healthcare encounter with an LGBTQ person, and kind of hearing their diverse perspectives would build that empathy up even more. And then to reduce disparities. So some folks talked about wanting to know more about the history of LGBTQ healthcare disparities, of injustices that have occurred in terms of healthcare, denial of care, all of those things. And that with Dell specifically, they learn about the disparities of different groups that they're going to be interacting with, and that LGBTQ folks haven't yet been singled out as a unique group that should be discussed in terms of a disparity. And they were wanting to know more about that. And then lastly, we touched on challenges and barriers. So what is getting in the way of improving LGBTQ specific healthcare education? A common answer was that medicine in general is slow to change. And that's, kind of institutionally, we know that those changes are hard to make. Another big one was limited lecture time, so that, programs are shifting to having most in-classroom lectures in the first 2 years of medical school, and then shifting to clinical work fairly quickly. And that within 2 years, there's just a huge amount that needs to be covered. And LGBTQ healthcare is just not a priority. And part of that is because it's not tested on board exams. So board exams are what kind of delineate the healthcare or education objectives. And because this is not one of the more classic physiological subjects, that it is not tested and therefore not prioritized by administration. And then finally, they touch on that some rotations happen within Catholic hospital systems. There's one here in Austin that folks rotate through, and in those hospital systems, gender affirming care is not offered. And so folks have to go outside of that hospital system to obtain experience related to gender affirming care, at least specifically. So I want to end talking about the trainees in terms of a quote, just if they feel prepared to meet the needs of LGBTQ patients. So this was a pediatrics resident who said that they feel prepared to treat, in general, medical emergencies as it pertains to kids and teenagers. But in terms of if a transgender patient came into an adolescent clinic, no, they would not feel prepared based on their experience in medical school and the training that they received related to LGBTQ populations. And then this was a second-year medical student that talked about that without actually taking care of patients in clinic, they wouldn't be able to identify where they make mistakes. So kind of calling back to that theme that emerged of folks really wanting the opportunity to work with LGBTQ folks in clinic. So I want to end this section with talking about kind of quick fixes and kind of what's going right, and some long-term aspirational goals. I have easy in quotation marks because I understand that nothing is easy in making institutional change. So easy might be more of like something where structural change doesn't need to occur. So part of that is just continuing with LGBTQ patient panels as a part of medical education. A lot of folks, I think almost all people that we spoke to identified that hearing from LGBTQ patients themselves was the most impactful in terms of helping them understand what needs to be done in healthcare encounters with those folks. Implementing LGBTQ 101 course in medical training, that it doesn't have to be, a semester long course, but it can be a 2-hour training that the trainees kind of identified would go a long way in terms of at least getting everyone to a baseline level of understanding, instead of having folks that are medical students that are queer themselves, that are interested in these populations, that are attending allyship trainings and kind of have all the knowledge, and then folks that aren't seeking out that information and don't know nearly enough. And then an institution, sort of an institutional fix, but to make the available training that already happens in medical school mandatory rather than elective. And then long-term goals, advocating for board exams to test on LGBTQ specific care, so that administrations have more incentive to prioritize that as a part of education. To create permanent relationships with LGBTQ oriented care sites, so that folks who are wanting to get that experience are able to interact with that patient population. And then just in general, and this might be, part of this might be demonstrating the value to administrations, demonstrating the value of this type of education, and encouraging them to prioritize LGBTQ specific information throughout training. Before I move on to LGBTQ adults, does anyone have any questions on anything I just discussed? And I'm going to take a sip of water.
I think there's a question in the chat. I'm not sure if you noticed.
Oh, I don't know if I can actually see that.
I
Yeah,
can read it out to you.
Okay, thank you.
So this is from Norian. Not being tested on board exams seems huge. Did you get the sense that this was the biggest blocker to teaching this material?
So it was actually only one participant that brought this up, and I was so glad that they did, because I hadn't even thought of it. I think it's kind of chicken or the egg, right? Because administrations don't prioritize it because it's not relevant. It's not relevant because it's not tested on board exams. So I think it's one of the biggest blockers. But it's also something that I don't know, as a psychologist in training, who to talk to about that. Like who needs to be aware of this, who's writing the board exams. So that's something that I am wanting to follow up on based on these findings, because I think it is huge. Yeah. All right, any other questions?
Hey, Lexie, I have one question. This is Sam. So I'm just wondering if there was any like conversation at all about creating like a potential specialization or like additional certification in med school. I don't know if you came across that idea at all talking to people, but do you think that would be like a potential workaround or like, you know, a medium-term step? Yeah, what do you think about that?
Yeah, I like that a lot. I don't think we had anyone speak about that. And I think that's exactly what you said, a good medium-term step but I almost wonder if we're not yet there because we're not even at offering any dedicated courses at all. That it's kind of, sounds like it's tossed in as a part of like urinary systems, reproductive systems, that it's like, oh, by the way, there are, you know, queer and trans folks that this would be different for. So I think medium step in the way of a small step is just having any dedicated lecture time to this. And then once you get people that are able to even teach these courses, I think then there could be sort of like a specialization. But I imagine that those will start popping up because gender affirming care in particular is such a medically involved process. And I know that there are people that are learning more about it, and I imagine that will trickle down soon enough.
Yeah, like as more people with expertise are getting into those positions of authority.
Yeah, exactly.
Cool. Very cool. Thank you.
Lexie, I had a question really quick.
Yeah, sure.
Did your research specify whether or not some of this LGBTQ training that was available whether online or elsewhere, had any content relevant to intersex education?
So we kind of tried to get at that. Like, was when you were taught about this, was it even broken up between non-heterosexual folks and non-cisgender folks? And it sounds like, half of the time it's kind of lumped together as one. So I think there wasn't a lot of that mentioned. I didn't hear many folks talk about intersex folks. So my guess is no. I think they're still at step one, which is breaking it out even amongst different medical needs for trans folks versus non-heterosexual folks.
Yeah.
All right, I will move on to LGBTQ adults. We had an easier time recruiting them, so I think there's a little bit more to get into. We talked to 19 adults total that were recruited via social media and LGBTQ Facebook groups in Austin. So we were originally hoping to recruit through Community Care, which is a federally qualified healthcare center here in Austin, because we were hoping to achieve a diverse sample in terms of race and ethnicity, as well as socioeconomic status. And then COVID happened and no one was coming into community care. So we kind of ended up having to resort to recruiting on Facebook and other social media. This is kind of the gender breakdown of our sample. 42% cisgender, 21% transgender, 21% genderqueer, and 16% non-binary, and 59% white, 26% Hispanic or Latinx, 5% Black, and this wouldn't all fit, but it was also 5% Native American, Alaskan Native, or American Indian, Alaskan Native, and 5% Middle Eastern, North African. So more diverse than our student population, but still not kind of the diversity that we were hoping to get out of when we were in talks with Community Care to recruit. So I want to start off with positive healthcare experiences, common themes that underlaid a lot of the positive healthcare experiences. So one that showed up a lot was letting patients self-define. So starting at pronouns, identifying pronouns for themselves, but also letting them self-define in terms of their sex assigned at birth, at the gender of their partners. A question that a lot of folks identified as affirming that I really liked was who puts what where in terms of asking about sexual encounters. So not that question in and of itself is not making assumptions about the genders of sex partners, of what body parts the patient and their partners have, and just the functionality of sex. So in general, just kind of letting patients speak for themselves and not coming up with any assumptions. Another common one was the doctor being LGBTQ themselves. So it was really interesting to see people talk about it was almost one of the first things they said when we asked about affirming care, was right away they would say, oh, well, my dentist is gay and he talks about his husband all the time and it's so fun and I feel really close to him, just the quality of their connection with their provider was really starkly different when they knew that the provider was queer or trans themselves. Correct use of pronouns. So that's, we heard a lot from folks that their paperwork asked for their pronouns, and then nurses, administrators, and the providers would not look at the paperwork at all and misgender them still. So it was kind of like a double aggression in terms of you made me write this down, and then you don't care enough to actually use them appropriately. So correct use of pronouns stemming from the beginning of the interaction all the way to the end to actually read the paperwork where folks are self-defining. And then an obvious one, and knowledge of LGBTQ specific care. So I want to emphasize a little more what I mean by that. And this is kind of a more broad observation, which is that participants were concerned that providers were not knowledgeable about the interaction of their identity with subsequent health concerns. So one, I think, really important example of this was a non-binary queer participant who talked about they were binding. And for those folks that might not know, binding is the process of flattening the chest to be more in line with their gender identities. So this person was binding, but it was worsening their asthma in the process of binding. And they talked about how when seeing their provider, their general care provider, they had to bring this up to the provider to say, I'm binding and I'm noticing problems with my asthma, which they were able to do. But they identified that it would be helpful for providers to ask folks, is there anything that you're doing to affirm your gender that you want to talk about with regards to your health? So, rather than just kind of lumping this person into, oh, they're queer, oh, you're queer, who do you have sex with, et cetera, but actually to think about all the subsequent health concerns that might come along with the process of affirming your gender. Another example of this was a cisgender gay participant who talked about the effects of like 3 decades of antiretroviral treatment on his husband that weakened his skeletal system. So he was having, he's had 2 hip replacements, surgeries, and a broken neck from a minor fall. And this participant actually identified that that's the things that he would expect an LGBTQ affirming physician to be aware of. That, they're not just going to say, oh, you're gay, you're having sex with other men, you need a prescription for PrEP. It's that they know kind of the other trade-offs that come with treatment of, or a PrEP prescription. To say that if you're going to engage in risky behaviors, you should be aware that there are these trade-offs or these medications that come with these side effects. So again, that kind of subsequent health concern that comes adjacent to an identity. One other thing we asked about was the physical office spaces of providers' offices and if those mattered to patients. So a lot of folks said that in general, signs, posters, pamphlets, all of those things are heteronormative, and that it would be kind of an easy fix to show representation of other groups in those processes. That there's almost never any visible queer or trans employees, except in those rare cases where their provider, self-disclosed that they were queer, but just in terms of like administrative people checking them in, that they always felt like the only queer or trans person in the room. That they appreciated gender neutral offices, especially in terms of gender specific care, like OBGYN offices. Several folks identified, I go there, it's not like pink walls and moms holding babies and whatever, looks like any other doctor's offices. That especially when it was that and urologists and that kind of thing, that it was as gender neutral as possible. And a lot of folks identified that the KIND clinic stands out, which is the sexual health clinic here in Austin that's oriented to the community, that there's rainbow flags everywhere, that right when you walk in, it's very clear that they felt welcomed there. I want to talk about common factors of negative healthcare experiences. Making assumptions about patients. So that kind of goes along with letting patients self-define. That's like the other side of the coin, right? To assume that because a person looks a certain way, that we know that doctor knows things about them. to not have LGBTQ specific healthcare knowledge, for the patient to have to ask questions themselves rather than the doctor being able to identify those questions. When we asked folks if negative healthcare experiences seemed intentional or rather out of ignorance, most people said that those were non-malicious, that it was just a lack of knowledge that kind of contributed to that. And then I want to talk about denial of care. So this brings me to like a broader observation, which is that denial of care only happened with participants who were gender diverse. And so one thing that I gleaned from these interviews is that the negative healthcare experiences of gender diverse people were qualitatively different than cisgender individuals. For cisgender folks, it seemed like negative experiences were sort of an inconvenience, or they were uncomfortable, you know, someone assuming that they needed to be on birth control or something like that, versus much more serious and more negative experiences for gender diverse folks. So this is a non-binary queer participant who talked about their experience in a psychiatric facility. That experience was really bad in terms of gender, given that the staff rotated every 12 hours. They were constantly misgendered, and they would call out the wrong name for giving out meds. So in this case, this person was there due to stress related to their gender, that they were hearing from family members that they should not go through with gender affirming care. And this led to them going to a psychiatric facility. And so with that being, you know, one of the mechanisms of maintaining that psychological stress, to then be there and be misgendered constantly and constantly reminded about their gender identity, you know, it was not a very restorative experience for them. This was another transgender participant, and they talked about, they actually defined it as medical abuse. That there was trauma involved in that process, and they said that they came out worse than they went in. So obviously I would call that more than a non-affirming experience, but they actually identified it as trauma. And then back to the denial of care piece, this was a transgender man who said that he was turned away from 3 different OBGYNs in Austin. They said, nope, we don't know how to treat you, we don't know what to do with you. And they said that it felt weird because it was all about me, and it made me feel like I was never going to find the help that I needed. So I think that piece speaks to there needing to be maybe more information available to patients, where this person couldn't find any resource to direct them to someone that would see them. They're just kind of calling and asking if they, you know, trying to make an appointment. And then they kind of have to go through the traumatic experience of being denied care and being othered in that process. Last couple points here, I want to talk about the effects of those negative experiences that people talked about. The number one theme was that folks did not return to a provider where they had a negative experience. And they would also delay or push off their checkups and dreaded appointments in general. So, you know, you can see how this easily contributes to the healthcare disparities that we know happen in LGBTQ populations, because these folks are having terrible experiences, potentially traumatic experiences, and then they're not getting regular care because of those, because why would you want to go to have a negative experience? And this kind of worsens all of those other healthcare problems that come up naturally. A really interesting finding was that folks crowdsource affirming providers on Facebook, that there's Facebook groups that exist, and folks will say, hey, I'm a transgender man. I'm interested in finding an OBGYN in Austin. Does anyone know a place that you know, will see me and is an affirming provider? And other folks will, it's really a lot of sourcing through word of mouth, because there's not really a good, you know, database that provides this information for them. So I want to touch on two pieces with this really quick, just that kind of an obvious point, but additional marginalized identities and low socioeconomic status will contribute to already negative experiences. So having a lack of insurance means that folks were unable to access regular care. They had limited options for care when they did access it. They had an inability to transfer providers after negative or non-affirming experiences. So it was they were limited to anything that, was free to MAP providers, which is the medical access program in Austin, or community care, to access any care at all. And then this quote from a participant I thought was really powerful. And they said that a lot of my healthcare experiences are intersected with being Black and being fat. Those identities impact the way I'm viewed, which impacts how I access care. A provider could be super affirming for my gender and sexuality, but if they're fat shaming me, I'm probably not going to go back to them either. So just a reminder that, this LGBTQ 101 course that the trainees identified as being helpful can only go so far in that kind of patient-centered care and needing to affirm all of people's identities, not just what might be most relevant to their healthcare need that day, is another important part of care. And then I want to talk about business briefly, which I never want to talk about business, but I think one of the biggest takeaways for me in doing this study was that there is a business case to be made for providing LGBTQ patients with positive healthcare experiences. So I looked up the most recent estimate I could find of Austin's LGBTQ population was 5.3% in 2018. And with the population that year, that translates to roughly 51,000 individuals, which, as we know, has probably gone up since then. So along with having that many people that need affirming care in town, we also know that those people are more likely to report their health as poor, develop HPV, develop a number of cancers, be obese, and be HIV positive. So all of those things translate to a greater health need, or a need to access care. And so with that higher need for care, we also know that LGBTQ folks are more likely to delay care because of these negative experiences. But because word of mouth recommendations are clearly important among our participants that we spoke to, I got the sense that a provider that is able to offer an affirming experience for people would quickly be disseminated amongst the population as this is someone you can definitely go to. It's something that if folks have if folks do, a minimum of just offering even above average affirming care, they're creating a market for themselves amongst this community. So yeah, just touching on that point that a number of participants sought out the same clinics. There was another clinic in Round Rock called Pride Family Health that a lot of folks go to. The Kind Clinic was named a lot, but there was also just, this doctor that I heard through Facebook that is really great with queer and trans folks. Yes, and then last theme I want to touch on is just aging concerns. I want to make sure there's time for questions. We asked folks what they're looking ahead at in terms of their healthcare needs. So as they get older, what are they nervous about? And a lot of folks expressed concern about elder care, that they would have a discriminatory experience in an elder care facility that doesn't know how to work with them. Also affording elder care, that it's expensive, that they are more likely to not be in touch with their families and have that familial support, that they're more likely to have lower socioeconomic status. Navigating family planning, so accessing IVF treatments or, affording those, navigating the adoption process, navigating the restrictions, policy restrictions that can prevent folks from accessing care or allow hospitals or clinics to turn away LGBTQ individuals and not provide them services. And then lastly, worried about potentially homophobic, cis-sexist family members making healthcare decisions for them. That if any case they were incapacitated, a lot of people identified that they would be really concerned that their families wouldn't respect their identities in that process, that they would make the wrong decisions. And a lot of folks actually went ahead in term to legally make sure that their partner was the only one who would be able to make their healthcare decisions. And that was kind of more with folks closer to midlife age. So I want to wrap up with easy fixes, and then kind of long-term goals. An easy fix is to display just more inclusive materials in the physical office space that would go a long way in terms of making people feel confident and comfortable with providers. That ensuring introductory paperwork has opportunities for the patient to self-define. So, baseline of pronouns, but even up to gender identity, that you're not just having male, female options on paperwork, and that you're ensuring that the staff are using those self-definitions at all points of care. That if you fill something out on the form, that you're actually reading it and you're actually using folks' correct pronouns and self-definitions. And then reducing the use of gender terms and assumptions when interacting with patients, just coming from a place of humility and curiosity and not making any assumptions. Long-term goals, encouraging and enabling more LGBTQ individuals to enter the medical workforce, seeing how affirming it was for folks to encounter other queer and trans people in their medical process, definitely underscored for me what a difference that would make in seeing yourself represented in people that are taking care of you. To create a searchable database of providers who have proven themselves to be LGBTQ affirming. So I think that can look a lot of different ways. And I know that I think HRC is doing a healthcare equality index. So I think folks are working on this, but maybe there's an alternative more regionally to folks crowdsourcing on Facebook, that there's some sort of certificate that providers can obtain that lets folks know that they've received a certain amount of training, something along those lines. And then lastly, this is something that I'm interested in, develop and offer training opportunities for current providers. And that's, both LGBTQ 101 and then more detailed care. So kind of what I was saying in response to Sam's question, there's starting to be experts in the field of gender affirming care and, creating opportunities for those folks to disseminate the knowledge that they've learned in that process, I think is something that the medical field, I would hope, is kind of working on. But I think something that for researchers and academics in this area, this LGBTQ 101 is something that feels doable to me, to pitch the business case to providers for having their employees go through this training, and that would go a long way in making a difference, that providing more people with positive experiences, which makes them come back to the doctor more frequently, which reduces healthcare disparities in the long term. So it's an ambitious goal, but one I think is definitely doable. Questions, thoughts, and feedback. And I have here my study team that worked on this. Nate, who's in this meeting, conducted interviews with me and was a huge help. And the other 3 RAs here who have done so much over the past few weeks in terms of coding this large amount of data, I really appreciate. And my advisor, Dr. Mike Parent, who I'm not sure if he's here. But yeah, I welcome questions, thoughts, and feedback, and I can go back to any other slides as well.
Do we get to clap even though it's over a Zoom meeting?
You can clap if you want, yes.
Woo! I'm kind of wondering about this like niche in the, or maybe just this opportunity to have more advocacy in like regional healthcare markets. Like how can, you know, we think about organizing advocacy groups that are known to the community in a certain city or a certain region, and that, you know, have the time and the resources to go out and kind of cultivate a list of providers who are affirming and who are already doing this stuff.
Yeah, I do think, yeah, Yona said in the chat that Out Youth has one, as does All Go, for more local provider resource guides. So I think that need is being filled by smaller organizations, but I think there is a need for some sort of system, like to, you know, so that it's not on nonprofits in every city to be doing that. There's some sort of more regulated system or like certificate or training that people have to go through to be listed. Yeah, I'm not sure. Pride has a list that they use for specialists. Okay. Yeah, Pride Family Health, and I think Brown Rock is the one that a lot of our participants went to. Yeah, so it sounds like there are these things, but I also know that we're in Austin, which is very different from most other places, especially in Texas. So I'd be interested to know what resources are available in other cities that are like these compiled lists.
Hey Lexie, it's Katie. Good to hear from you and your research. I was thinking about how you mentioned like a future direction of your work would be to look into like what providers, what their perceptions are, and how they might make changes in their practice to work with people in this community. I was also wondering if you had any thoughts about reaching out to the medical providers in education to see how they might implement some of this in their coursework.
Yeah, so because we worked with Dell closely in this project, Dell Medical School here in Austin, I think my next step is going to be trying to reach out to those educators to just see if they're interested in hearing our findings, because we did talk to, you know, residents and medical students, and then also community members. Because I think getting their buy-in is a big part of this, and whether it's connecting them to resources or educators that are trained in this, you know, to bring someone in, or just see what their flexibility is in terms of their coursework timeline, I think is a good next step, because I think it starts, like there's two pieces of it, which is teaching trainees now, and then kind of retroactively teaching current providers who definitely didn't get any training on this. I think there's different needs for those two groups, because medical students now are learning some things, but not enough. And then folks who have a lot of clinical experience are going to have to integrate these like new things into what they've been doing for years. So I think those are two separate prongs of next steps. Yeah.
Right. That's exciting. Thanks.
Yeah. Asher said in the chat that the older providers are the hardest audience, that they don't want to prescribe PrEP or retroviral therapies, much less learn how to be affirming. Yeah. There was a lot of talk about like the old guard among medical students, that it's old providers who've been doing the same thing forever and don't see a need to. There's also, you know, the sense that like someone like a cardiologist would say, you know, why does this matter? Why do I need to know about how to interact with this population? But there's still a way to be affirming to people, even if their concerns are related to their heart, which is not related to their gender identity. So I don't know how to solve that problem for sure, but you know, especially if what they've been doing has been working for them. If it's someone that is a primary care provider and they've just been chugging along for 30 years and they have plenty of patients, you know, why take on this extra burden of education? But something else we talked about is not from our participants, but just among our lab when we've talked about like working on this problem, it's maybe it's creating CEUs, because doctors have to get a certain number every year, and maybe a training along these lines. You know, not that maybe those older providers wouldn't sign up for it, but some people would. And yeah, I think we need to know more about how to best work on that population. Meg in the chat. Wonder if the similar case can be made from a policy perspective, that SGM questions are supposed to be integrated into EHRs. And I wonder if more policy moves could be effective. I think I understand what you mean in terms of like that an EHR is a software that is being distributed, and like to push for those to be inclusive of SGM concerns. Is that what you mean?
Yeah, I think I just mean like normalizing the act of asking people about their sexual and gender minority identities, and that coming from a higher level policy place could help physicians know and understand that it's not a choice that they have to make. It's just the policy of the hospital or the university or the state or whatever.
Yeah, I think that I see a parallel with that and the board exams, right? Like that's the policy push on the education side is, you know, you have to make this matter. You have to make people want to learn it. And so if a primary care provider is all of a sudden being prompted to put in someone's pronouns and gender identity and sexual preferences or whatever, that might prompt them to want to learn more. That's a really good thought. I really like that. Yeah, there's
Well, y'all, I do want to be cognizant of the time. It is past 4 o'clock. So Lexie, if you're willing to stay on and people have more questions, I'm totally cool with that. Otherwise, great presentation. Thank you so much for sharing your work, and would love to stay in touch as that work progresses and you take next steps. So thank you so much for sharing all that you've done with us today. Really appreciate it.
You're welcome. Thank you everyone for coming. I appreciate it.
Thanks, Lexie. Good job.
Cool.